And now I am so honored to introduce you the moderator for today. Theresa Malloy Miller has been a member of Patients for Patient Safety Canada for over 10 years, and she's also a champion with the World Health Organization Patients for Patient Safety Global Network. Theresa started her journey in being a patient partner because of the loss of her son. A tragedy turned into an advocacy and an amazing partner who has been active with our group for many, many years. Recently, Theresa is leading the Knowledge Transfer Working Group of Patients for Patient Safety Canada, a group that started with transferring knowledge among the Canadian members of the group, and then in collaboration with the World Health Organization, we started to have those global webinars. So those of you who attended in the past, you already know Theresa. And those of you who do not, you will enjoy her expertise and her moderation in a little bit. So with this, let me welcome Theresa calling from London, Ontario, Canada. Theresa, over to you.
Thank you, Iona. It's a pleasure to be with everyone today. And as Iona said, we started in 2013, Patients for Patient Safety Canada, to develop webinars, and we started really to focus on our own members to increase their capacity about patient safety. And we quickly realized that there is likely a wider audience. So then in 2015, Patients for Patient Safety Canada, which is a working group of the Canadian Patient Safety Institute, developed webinars in partnership with the World Health Organization. And then finally, in this fall, September 2017, the relationship with the World Health Organization became more formal, and the Canadian Patient Safety Institute became a WHO collaborating center. So we have really set a course to work globally to build patient safety knowledge and capacity on a global level. So we're delighted to be developing this first topic, medication safety, and this is the first time we've done a series of webinars. So we hope over the next month to dig deeply into medication safety. And we're delighted that this is the first webinar in this series. So you can see we'll look at the objective for this webinar. And I'm just going to bring up that next slide. There they are. So you can see the objectives there. What we're really hoping is that everyone will leave with at least one very practical idea that they can use. We have a wonderful lineup of speakers, and you can see that they are going to help us to understand this very global issue of medication safety, what the size and the extent of this problem is, and factors that lead to that. We are going to hear very specifically about this WHO Global Patient Safety Challenge, about medication without harm to get there. Our speakers are going to help us to learn some ideas about how we can prevent harm from medication. We have a very specific example we're delighted about, to have a glimpse into Israel and to look at primary care there and how patients are involved in medication safety. Close to my heart, we are going to hear about ideas of how to partner with patients and families and the public to include everyone in making sure that medication becomes safe for all of us. So with that, I am delighted to introduce our first speaker. Kathy Kovacs Burns is a member of Patients for Patient Safety Canada. We're delighted about that. She also has many other hats that she wears. She's a member of other local, national, and international patient organizations like the Best Medicines Coalition and the International Alliance of Patient Organizations. She is also an academic scholar. She's a professor and researcher with the School of Public Health at the University of Alberta here in Canada. She's a senior manager in quality health care and improvement with Alberta Health She partners with patients, families, public, and other stakeholders to be involved in very meaningful dialogues that include research and measurement. That's her expertise. But she pushes forward to get involved in decisions that lead to the improvement of access, quality, person-centered care related to health services. So with that, I'm going to hand this over to Kathy. She's taking her hat as a member of Patients for Patient Safety Canada. She's going to describe her family story and lead off this discussion and really highlighting the importance of family and patient involvement in medication safety. So Kathy, thank you for joining us today.
Good morning, good afternoon. Can you hear me? Am I coming through?
Yes, I can hear you. Yes.
Okay. I apologize. I have a little bit of laryngitis, but hopefully that won't interfere. So, but it's my pleasure actually to be part of this discussion this morning, or this afternoon for some of you, because there is certainly for me a personal story. So I wish to share that with you. It's not my own story, but it's a family member's story. So I'm going to, now I'm just going to back up the slide just a bit. Here we go. So I always say, you know, since my experience with my family, that one can never be overcautious when it comes to personal or family member medications. That there's an understanding that we all need to have that, you know, when in fact you're given a prescription, that it's not an entitlement to actually say that it's the safest or the best product necessarily, or that it will take care of you in terms of your illness. There are a lot of things about medications that I've learned since the incident that happened with my dad. But I just put that out there, that it's a lesson that I have learned.
You are now muted.
I hope that others too realize that there are certain things that we can do to prevent medications from becoming adverse events for us. So with that, I'll tell you a little bit about my dad's experience. And
We lost you, Kathy? Just thinking we are having a little, this is Theresa again, we might be having a little technical problem. And I'm sure Janet's in the background reconnecting Kathy's audio.
oh, hi.
Okay, there you
Hello,
are.
can you hear me?
Good. Yes.
Yeah,
We
so a voice just came on.
Okay.
Yeah, I think I heard a voice saying I was muted and then I was not muted. So.
Oh, okay.
Anyway, so just to start over a bit here, so I'm going to just tell you the story of my dad's experience and what I consider to be our family's worst nightmare, but it's turned into a lesson I think that we have learned and certainly used along the journey. So in 2013, my dad was 86 at that point in time. He certainly was, I think, one of the typical, I shouldn't say typical, but, you know, there are seniors who, in fact, have multiple medications they're taking for multiple conditions. And my dad was one of those. He was taking medications for his heart. He was taking medications for his blood pressure. I'm not sure that there was much else, you know, diuretics, things like that. But anyway, on December 5th of 2013, my dad went in for an annual physical exam, and he's prescribed a new medication. My dad is the type of person who doesn't ask a lot of questions. He's pretty compliant, and he listens to his doctor. He liked his doctor, so, you know, there was no reason to actually question why he was taking the medication or for the reason for taking it and what he needed to know about the medication before he filled it. Anyway, he filled the medication, and he started to take it. At 3 a.m. the next morning, my dad wakes up with intense head and chest pain. And his explanation to my mom was that he felt as if his head was going to explode, and he couldn't breathe because his chest felt as if it was being compressed, and he was just in such intense pain. So my mom called my sister, and my sister immediately gets dressed and wants to run over because she's just not sure exactly what's happening, and my mom's not describing things quite well. So she heads over in her car. In the meantime, she's calling me at 3:10, 3:15 a.m. and she describes to me what's happening. And so I'm a little upset, that in fact they just didn't call the ambulance. So I said, just call the ambulance now. I mean, what are you waiting for? Like when he said his head feels like it's going to explode and his chest is, he's in pain. I said those are signs to me that are symptoms and signs that he needs to go to the hospital. So they called an ambulance, and the paramedics arrived, and they assessed him en route at 3:30 a.m. By 4 a.m., the emergency docs diagnosed already at that point just by putting him on a ECG and doing some other tests that in fact he had suffered a heart attack and was experiencing some mini strokes, and hence the feeling that his head was ready to explode. At that point in time, they just decided that they better stabilize him. They had really no communication with my mom and my sister at that point. They were just anxious to be able to stabilize him. So my mom and sister really didn't know what was happening. So this was 4 a.m. in the morning. So I was already en route. I booked a flight, so I was able to get on the early flight from Edmonton to Lethbridge, where my parents live. So 4 a.m. to 6 a.m., they administered a number of different tests, blood tests and scans, and a confirmation of the diagnosis, and he was admitted to ICU immediately. And what they ended up doing was then coming out to talk with my mom and sister, and they said, they needed to have a list of my dad's medications because they were finding some incongruities in terms of some of his blood work and so on. So my sister had a medication list, but she also ran home to get a bag of his medications to bring it to the emergency department in case the list wasn't accurate. So, of course, in the bag was the most recent prescription. Anyway, they reviewed things, and so by the time I arrived in Edmonton and got to the hospital 9 a.m., the cardiologist actually came out to meet with us, and he told us at that point in time that they were pretty sure, although they were still doing tests, pretty sure that in fact my dad had experienced an interaction between some of his medications. And so the last medication he was prescribed was contraindicated with one of his cardiac medications, and that actually initiated the whole event from the chest pain and the heart attack to the mini strokes. And so they wanted to know why he was prescribed the last medication, and we said, well, we don't know. I said, I don't know. I mean, and he said that it was actually a medication that was prescribed for Alzheimer's. Okay, we were quite shocked because we didn't think my dad had Alzheimer's. But anyway, so this was what we were told. As we went through the process following that particular event and discussion with his family doctor felt that he was at a point in his life where he was getting a little bit of dementia, and he prescribed the Alzheimer medication at that point in time. But no one had bothered to check that, in fact, this was actually going to interact or was contraindicated with some of his other medications. The pharmacist also did not pick up on it. And so, when my dad took it, of course, there was this event. But we did learn that, in fact, my dad didn't have Alzheimer's, so that was a tragedy in itself. There was no real testing or diagnosis that was founded in terms of some of the basis for what the prescription was meant for. So in that whole course of events, we learned a lot about the fact that we started to question and needed to question more some of the things that were actually happening in terms of treatment and medication. So rule number one for us was that we were wrong to make assumptions about the medications prescribed. And I know that many of us make the premise about prescribed medications, you know, that the assumption is doctors are right and therefore we should probably comply. I mean, we are told that we should adhere. But, you know, in terms of looking at that whole aspect of the prescription and a good reason for why we need to have it or take it, there's a lot of questions we need to ask about that to be sure that it actually is something that we need to have in terms of our condition. And if, in fact, there is going to be an interaction with any other medications, we also assume that doctors have personal information on our files and knows that we are taking medications for certain conditions, and therefore they should be checking. We would never consider asking for a second opinion or asking you questions, and certainly my dad would never do that. And, you know, you assume that the medication you're prescribed should be safe to take, even with multiple other medications. And so therefore, you know, there's a number of things that we were assuming. And my dad, too, often said that he would never ask his doctor or pharmacist a question, and, you know, for fear that he really wasn't asking the right questions. So there were a lot of assumptions, I think, that we all made. Rule number two for us was that we had the right to ask questions about what we have been prescribed and or our treatments as well. And that would, in fact, there in this particular tool, that there are 5 key questions that we could ask. I know that there are other tools that are coming out now, and there's one that's called 5 Moments tool that I think is still in pilot phase. But it's still asking some of the key questions around the medications themselves. So number one here is the changes. Have any medications been added, stopped, or changed, and why? Do we continue with the medication? What medication do I need to keep? And if there's any that I can actually take off my medication list, is there going to be a contraindication or interaction with my medications? And you know, the proper use around medications and taking care of them. Sometimes they need to be taken with food, other times they don't, and so on. And monitoring, how will I know if my medication is working and what are side effects I should be watching out for? And then, of course, the follow-up. So I think these questions were pretty key for us. There's probably a few others we added to our particular list as we went through the event with my dad. But what it has taught us since that day is that every time he goes into a doctor, in fact, anytime all of us go in, we ask the questions around any of the medications we are prescribed or any other tests that are being done or prescriptions or, you know, things like that. And I think that that's important. You have the right to do that. It's not saying that you doubt, you know, what the physician is saying or your pharmacist might be saying, but what it's saying is that you need to know. And if there is a question that seems to be not asked around particularly contraindications, then, you know, that might be picked up at that point in time by the pharmacist or the doctor. So there are reasons for actually asking those questions for many people involved in your care or your family member's care. Rule number 3 for us was to understand your disease and conditions and reasons for treatments and prescriptions. I mean, the best motto is that you know your body best. And so if, in fact, there are any times where, in fact, there seems to be something happening when you're taking a medication, you should be able to identify that and ask those questions of your pharmacist and or your doctor. So if you're prescribed a medication, there are key things that we always say now for my dad to ask or for us to ask. So what are they? Why do I need them, or why do you need them? What are possible things I should be watching for, particularly side effects, and how long will I need to do this? And other questions that come into mind as well. Never assume that your questions are stupid or that they're minimal in terms of what it is that you need for information. If you don't understand your condition or understand your medication or treatment, then you could experience an adverse event, such as my dad's. And so to prevent that, there are means of doing that through the questions that you might ask your physician and certainly your pharmacist to follow. And then I think some of the things that we did learn also is we started to talk with the cardiologist and the other physicians in the emergency department. And as my dad stayed in hospital for 3 months, so that particular December and through Christmas, he was in the ICU, and not a place that he wanted to be, but it was such because of the contraindication in his medication. But he is alive today, and he survived, and he's okay. He suffered some side effects and some detriments, but he's okay. And so we know now that we really need to understand what the medication history is and the list that we carry with us, but also to be really sure that we understand what it is that each particular medication is for and what it does and what possible side effects there might be. We understand about medication reconciliation. And so each time my dad goes into his family doctor, so do I really need to take this? Or is there something that can be removed from my list? Or, things like that he is now pretty conscientious about. And in fact, I can tell you that when he was reconciled in the hospital, there were 5 medications that were removed from his list because he really didn't need them. So, and he's now on 3 medications, which I think, says something about that fact, that how important it is to review one's medication list, and that polypharmacy that we are so inclined to understand as being somebody else's problem, not necessarily ours. The medication review, and then the management. And I think this particular model that is up on the screen is one that I've learned to use, maybe not as layperson language useful for someone like my dad, for example, but he does understand what his medication history is. He understands the word medication reconciliation now. And so, as you go through this kind of event, it alerts you to being a little bit more tuned for some of the things that you really need to watch out for and to manage your own medication and your conditions. And we always talk about, babysitting our conditions, because that's really what it is to manage your condition in a way that you are really looking at it from a 360-degree perspective, including the medications you're prescribed and what it is you need to follow up with your specialists and your pharmacists. And I think that really is my last slide. So thank you for listening to my story and what the kinds of lessons we've learned in terms of the event that we've experienced as a family.
Thank you, Kathy. That's a very powerful opening for our discussion today. We are going to move on to our next speaker, and then we will stop and we will have some question and discussion. So our next speaker is Dr. Dhiren Cherian. He is a physician from India. He's specialized in clinical pharmacology and therapeutics. He's currently pursuing a master's in medical law and ethics. He works in the Patient Safety and Risk Management Unit of the World Health Organization, where he is focusing on the medication safety domain, and he's part of this 3rd Global Patient Safety Challenge of the WHO about medication without harm. When Dr. Cherian was in India, he was an academic and later a medication safety officer. He has experience in the implementation of effective medication safety strategies. His passion lies in system redesign and reinforcement in detecting and reducing medication harm. He is going to provide us with a background to the WHO Global Challenge about medication safety. So welcome, Dr. Cherian. We're delighted to have you.
Thank you, Theresa. Good morning or good afternoon, depending on where on this planet you've logged in from. And I bring greetings from the Patient Safety and Risk Management Unit of WHO. Just give me a second while I load my presentation. Can I have a confirmation whether the slides have shown up?
Yes, I do see. Yes, they're right there.
Thank you. All right. So, Dr. Neelan, the coordinator of the patient safety unit, sends her deepest apologies for not being able to speak at this webinar due to some conflicting schedules. And so hence I'm presenting on behalf of the unit. We would like to commend and acknowledge the good work the Canadian Patient Safety Institute has done as a WHO collaborating center in organizing this webinar series. During this webinar, WHO will showcase the third Global Patient Safety Challenge, Medication Without Harm. So during the previous session, I had interruptions in the audio, but essentially what Kathy was trying to say is we should not make assumptions about the medicines that we're taking. We should have the confidence to ask questions to the healthcare professionals who are prescribing or dispensing medications to us, and we should understand our disease and the medications that we are on. And she also broadly spoke about the 4 different things such as review, reconciliation, medication history, that we need to, as patients, engage with our healthcare professionals to constantly do as an exercise for our medication. Now, we heard about a medication-related harm from Kathy just previously, and these unfortunate incidents are sometimes preventable, which is a sad truth. Each of these incidents, like the one that Kathy just mentioned, are huge repositories for learning. Like most of the high-risk sectors, which have learned and evolved from mistakes they have made, it is time the healthcare sector does the same. And the essential message for this program is a quote from the WHO Patient Safety Envoy, Sir Liam. I quote, "To err is human, to cover up is unforgivable, and to fail to learn is inexcusable," unquote. Now, there are many individuals and groups in the field of pharmacy, medicine, nursing, and other professionals who have been fighting for decades to bring the spectrum of preventable error under the spotlight. It is in this context that WHO is initiating the third Global Patient Safety Challenge with the theme of medication safety. The previous 2 challenges have focused on an area that represents a significant risk of patient harm, and they have been clean care, safer care, and safe surgery saves lives. And they were aimed at reducing healthcare infections and risks associated with surgery, respectively. These were extremely successful programs and secured strong commitment from health ministers, professional bodies, regulators, health system leaders, civil societies, and even the healthcare practitioners. Drawing on the experience of these programs, the third challenge was launched in March 2007 at the Global Ministerial Summit on Patient Safety in Bonn, in Germany. Now, this program will drive a change process aimed to reduce patient harm from unsafe medication practices and medication errors. As part of this challenge, WHO launched a global campaign directed at all stakeholders, including patients and the public, healthcare professionals, and policymakers, with the catchphrase, "Know, check, and ask." WHO released a video as part of this campaign to engage all key stakeholders, as well as merchandise that people could download from the WHO website and use for free. You can find more details of the campaign on the link that's shown below, and we encourage everyone to circulate these materials. WHO also organized 2 regional launch events of the challenge in the Eastern Mediterranean region and in the Western Pacific region, where representatives from various health ministries signed a pledge to prioritize medication safety. Medication-related harm is a broad concept, and not all harm results from erroneous use of medicine. And that's quite important for us as patients or even healthcare professionals to understand. It is important to understand that the use of some medicines is associated with an inherent risk of harm even when used correctly. So these are adverse events and not necessarily a result of errors. Thus, not all medication-related harm is preventable. However, most of them can be avoided by strengthening the systems and practices of medicine use. So these are the areas that this challenge will try and address. Assessing the global burden of the problem is challenging as there isn't much data from many countries. A landmark study published in 2012 estimated that the annual global cost of medication errors is around $42 billion. This is roughly 0.7% of the global expenditure on health. And it far surpasses the entire health budgets of many countries. Now, most studies that estimate the cost and health outcomes of medication errors is from high-income countries. Now, for example, a study from the US showed that more than 1.5 million patients are injured every year in American hospitals, and the average hospitalized patient experiences at least one medication error each day. The estimated cost of treatment for these patients was about 3.5 billion US dollars. Now, similarly, a study conducted in 10 English hospitals showed that about 5.2% of the 1,000 deaths reviewed were preventable, and about 21% of these were due to inadequate medication management. Now, these numbers are indeed shocking, and unfortunately, there is not much comparable data from lower middle income countries, but the situation is likely to be very similar, if not worse. Recognizing the scale of avoidable harm linked with unsafe medication practices and medication errors, WHO launched its third Global Patient Safety Challenge with the goal of reducing severe avoidable medication-related harm by 50% over the next 5 years. The strategic framework of the challenge revolves around the 4 fundamental domains that you can see on this slide: patients and the public, medicines, healthcare professionals, and systems and practices of medication. Patients and the public are not always medication savvy or medication wise. Often what happens is they are passive recipients of therapeutic decisions made with inadequate participation in the process, and patients need to be informed and empowered to play their part in making medication safer by being involved in therapeutic decision making along with their healthcare providers. Medicines are sometimes complex, and these complexities can lead to errors in various steps, including prescription, dispensing, preparation, and administration. Now, providing adequate, easily accessible scientific information about medicines to the healthcare professionals is very important and could play an important role in avoiding many of these errors. Another important problem resulting in medication errors is the confusing look-alike and sound-alike packaging and labeling. As for healthcare professionals, especially in resource-limited settings, sometimes they prescribe, dispense, and administer medicines in ways that increase the risk of harm to patients. The last domain, complex systems and practices of medication, can sometimes be dysfunctional and error-prone. The designing and engineering of resilient health systems can significantly contribute to reducing avoidable medication-related harm. Now, these are the 4 domains around which the challenge is built. Given that the subject of medication safety is so vast, the approach adopted by the challenge aims to reduce severe avoidable harm caused by unsafe practices and errors by specifically addressing the weaknesses of service delivery and developing more effective healthcare systems. For this purpose, early priority is directed to 3 key action areas: polypharmacy, high-risk situations, and transitions of care. And WHO is in the process of publishing a technical report in each of these series. So we will go through each one of these key action areas. Polypharmacy, or simply put, the use of multiple medications, can sometimes lead to medication errors. Now, this is an important cause of concern, especially in the elderly who have multiple diseases and hence are often on multiple medications as well. And in studies that analyzed preventable hospital admissions, it was identified that patients older than 65 years and patients on more than 5 medications had a higher risk of preventable adverse drug events. This does not mean polypharmacy is always dangerous. What is important to note is that while polypharmacy is sometimes required, it increases the chances of having interactions between various medicines and may result in adverse outcomes. Now, the appropriateness of various medicines can be ensured through a systematic review process by your healthcare professional. High-risk situations are often found in healthcare systems, sadly. These could be contributed by patients, healthcare professionals, complex medicines, or a weakly designed system. It is important to identify these high-risk situations and to build in risk reduction strategies to prevent them. Adopting a proactive approach to periodically self-assess risk situations, integrating forcing functions, and appropriate technology to prevent errors, limiting the access of high-risk medicines, standardized labeling and packaging are some of these strategies that could be employed to prevent errors ensuing from high-risk situations. Transitions of care is when a patient moves from one level of care to another or from one healthcare facility to another. For example, in the figure that you can see on the slide, when a patient arrives from home to the emergency department or subsequently gets transferred from the emergency department to the, let's say, intensive care unit, he or she has been through a transition of care. Now, the points in transitions of care are sometimes associated with unintentional discrepancies in the medication. Various studies have shown that between 25 to 80% of patients experience at least one unintentional medication discrepancy at discharge alone, and that's just one point in transition of care. These are the early priorities for global action, and WHO will work with international experts, partners, and interested stakeholders to develop guidelines, tools, and technologies in these areas. WHO brought together more than 40 leading experts in the field of medication safety during the meeting in the second week of December. These experts, together with WHO on the medication safety curriculum, implementation plan for the challenge, development of evaluation tools, patient tool, and the research priorities are the key domains in which we intend to take our work forward. In the planning phase of this challenge, a meeting was organized where Helen Haskell, the next speaker, moderated the working groups on patients and public. Now, Helen, along with Irina, a WHO consultant, has been assisting in the development of this patient tool. As part of this process, the working group developed a draft tool, and I'm sure that Helen would discuss at least some aspects of that in the next talk. And in addressing the global overall goal of this challenge, WHO will work with a wide range of stakeholders, including ministries of health, national coordinators or program managers, health system leaders, educational institutions, regulatory agencies, patient organizations, etc. Now, sooner or later, we will all need medications, and we will need to use medicine safely for our own good. And we need to join hands to catalyze this long-awaited change and strengthen weak healthcare systems to achieve medication without harm. Yeah, so that's my last slide. Thank you. Thank you to CPSI once again.
Thank you, Dr. Duran. You've given us a very complete global picture of this challenge. So we have a few minutes now to entertain some questions. And Iona, I'm going to ask if there's any questions in the chat box that we should go to.
Hi, Theresa. There aren't any questions except that I had one for Jiren, and a big thanks, Kathy. But before I go there, I want to ask the participants to go to the chat box and add their questions there if they can. The chat or the Q&A, either one is fine, whatever works best on your computer. So Jiren, what I was hoping is if you can give us a few examples of medication incidents that fit in the three categories which are aligned with the goal of reducing 50% of incidents over the 5 years. And maybe a few examples of what is not that goal. I think that the participants, especially the patient partners on the line, will be able to relate a little bit better if they have a few examples.
Thank you so much, Iona, for that question. Yes, and it's also a very important question because, like I was trying to say in my presentation earlier, not all of these adverse outcomes are preventable, and not all of them are necessarily because of system-related errors. One such example where there is unavoidable or mistakes that cannot necessarily be prevented is an example where a patient requires an antihypertensive, that is a medicine required for blood pressure, and they do come with some side effects like it drastically brings down your blood pressure, and the patient can fall because of a syncopal attack. So those are not necessarily because of a system-related error. Now the only step that can be done is that the patient is informed about this risk of the medicine by the healthcare professional before dispensing. But coming back to severe and avoidable harm, which is the main focus of the challenge, in the three areas, what we would like to encourage patients and the healthcare professionals to do together is to conduct a proper medication review occasionally, where the healthcare professionals decide along with the patient if the list of medications that they take are really necessary, and if some of these medicines can be either reduced in their dose or stopped altogether, or if there's an alternative medicine which has got a better safety profile. So that's one of the things that patients and the healthcare professionals could do together. Now, another thing that the challenge would try and focus is to encourage patients to have a list of their medicines that they should always carry around with them, especially when they need medical attention, when they go to a hospital, so that the healthcare professional who sees this patient knows which are the medicines that he or she is on, and can titrate or prescribe subsequent medicines accordingly. Now that is called a best possible medication history, and that's something that Kathy had shown on during her presentation as well. Another thing that patients could do is be motivated and be courageous enough to ask the healthcare professional if they don't know enough, and not to assume things about their disease or about their medications. Now these were essentially again spoken about by Kathy in her presentation. So these are the things that the challenge would try and encourage patients to do along with the healthcare professionals to avoid severe and avoidable medication-related harm.
Thank you.
Thank you, Dr. Jern. I have a quick question for Kathy. Kathy, you described how initially that your father is a very trusting, accepting person, and it sounded like you shifted him. And I wondered, could you talk a little bit how you supported your dad to become a little more active in questioning about his medication?
Yes, certainly. Can you hear me?
Yes.
Okay. So I think, it didn't take very much to convince my dad that he had to approach things quite differently in terms of his medications and his treatment with his family doctor in particular, but even his specialists. And he's always, been around his daughters. He's got 4 daughters, all of us fairly educated, and always saying, you need to ask more questions about stuff. So I think that it didn't take very much for him. After the event, he realized that he needed to actually take responsibility for his own care and ask the questions. At one point I'd escort him in after he got out of the hospital, escort him in for several of his appointments, and I could notice that he actually was taking being a little more assertive in asking the questions and being fairly polite about it. Sort of saying he just wanted to know. He wasn't questioning, the doctor's expertise, but just needed to know for himself all these pieces. And I thought he did a really good job of that. But it took the event. He just didn't want, he said he didn't want to die. He wasn't ready to die. He was healthy up to that point, and he just realized that there was one thing he could do to prevent, his death or, other kinds of serious complications. So it didn't take much.
So did you generate a list with him? Like you used that 5 questions to ask, or did you just have sort of a mental list? Do you have a visual list?
Yes. So, I actually dug up these kinds of tools so that we could go over them as a family and talk about them, because nobody actually gave us any tools at the hospital or anywhere else, even the pharmacist. So, because I had been part of Patients for Patient Safety Canada, I think, I knew that there were tools available that we could actually look at, little checklists. But he does take it a checklist with him. We actually drew one up where he could actually write notes beside, some of the questions he would ask the doctor, so that we could review them with him after his appointment. These tools were quite helpful, going over them and allowing us to create the kinds of questions that would be easy for my dad to ask in his own language. So it would be really, him that's talking, and he'd understand exactly what he was asking and what information he needed. So, but yeah, the tools were quite helpful.
Good. Thank you for that clarification, Kathy. She's currently a Health Information Accountability Officer working in improving the quality of health information at the Israeli Health Ministry. She's a graduate of the Hadassah Hebrew University in Jerusalem Medical School, where she completed her residency in family medicine. She also holds a master's degree in health systems management from New York University, and she continues to practice in Jerusalem, where she resides with her family. And Yael is going to give us that frontline perspective of a physician working in partnership with patients and family related to medication safety. So we're delighted to have you here, and I'll hand this over to you, Yael.
In the meantime, I just want to let you know, Theresa, that we had a few more questions in the chat box.
Why don't we go to that? Okay.
You want to do a question? Sure. So Fred mentioned in the chat box that as a nurse, my problem is with a significant workload, not having the opportunity to do a lot of teaching with patients, especially patients who are on 30 medications. Beyond the medication reconciliation process, are there any suggestions about how I can educate and teach despite a very busy work schedule? I think Fred is reflecting a reality in many places. So let's see if any one of the speakers is willing to take a stab at answering this question.
So we'll pass that back over to Kathy or Jiren and see if they would like, in that very a patient with beyond multiple medications.
Mm-hmm.
Jiren or Kathy, do you want to take that question on?
Yeah, thanks, Iona. And Fred, thank you for this question as well. So these are very pragmatic problems that healthcare professionals face when dealing with patients and these demanding circumstances, when there are too many patients, the patient load is high, overworked health staff, inadequate resources. Now these are all very practical problems. Having inadequate staff is one problem, but having inadequate systems in place to tackle these difficulties is another. And when we talk about medication errors and system redesigning, what we would try and encourage is to have systems in place so that these kind of situations can be avoided to the extent that is possible? Yes. So that's what I would think as an answer, Fred. There are very pragmatic difficulties in each of these situations, which we understand because even I was a healthcare professional, I was a physician, and we have these problems as well. Yeah.
Kathy, I'm wondering if you can add on to that, from the patient perspective. Is there a role for patients and families? Because we know healthcare providers are so overworked. Is there a role for patients and families as they take on responsibility to ease that load? Can you give us your sense of that? Do we have Kathy with us still?
Yes,
Kathy?
we do. She also needs a moment to get unmuted.
Oh, okay. Boy.
Oh, I'm no longer muted. Okay.
Okay.
Can you hear me?
Did you hear that question?
Yes, I did. Yeah.
Okay.
So, I think I've certainly come to appreciate, the situation that most health practitioners face, whether they're in hospital or even in clinics. It's that you don't have the time to spend totally on one single patient, and I think that's where patients and their families actually come into play. I think it takes time actually to go through and reconcile one's medications. You can't sort of cut somebody off, off of them and start all over. Like my dad, I mean, he was actually taken off all his medications while he was in hospital, and they started over. And then realized, he really did not need all the medications he was on. But, you can't do that for everybody. I think it takes time to work through that process. But I do believe that patients and their families can actually start asking those key questions about each one of the medications that they are taking and what it is that's happening. I mean, what is it for? Do they really need it? I mean, how long do they have to be on those, and do they really need it? And if they go off, I mean, what sorts of things can they look for and watch for? And I think that between the family doctors and the family and that conversation that you have around asking the key questions is an important one, but it does take time. I would take the pressure off of people within the hospitals, because I don't think that's it might not be the time or setting for reconciliation of medications. On the other hand, if the patient is going to be there for a while, maybe that's something that can be discussed between the nurses, physicians, and the patient and family, and maybe that is a time to start it. But it's not an easy process, and I can appreciate that the overload that many health practitioners are facing. But I just think that patients and families have to take some of that responsibility and just be attentive to whatever it is that they are taking, and what they need to do to reconcile that particular medication list. So it does take a while.
Is there something that needs to happen on the system level to allow patients and families, or to support patients and families to take on that more active responsibility role? There are some key things that have to open up?
Well, certainly I think the system has to, I think some of the problem is that, there isn't a direct connection between family physicians and pharmacists. The actual electronic files are not being transferred, and so you really don't have people looking at those files in a way that they can actually start to, ask the questions, do you really need to be on this medication? And maybe we should have a look at that, So I think that is a system problem, is that the records are not linked. I know that Connect Care is something that is being worked on in Alberta, but it's something like that we need, where patients can actually also see their own records, and have that input. On a broader system level, it's pretty difficult to know where to start. But because I don't think, as I said, it may not be the right setting or the right time in terms of the hospital. If somebody's transitioning, that might be the time to start to look at some of those medications and what they're taking, because they may get different medications in hospital, and when they leave and get a prescription filled, it might be different again. It might be on a generic versus a brand, for example. So, you know, that's all the kinds of things you have to sort of be aware of, because the system isn't linked. It just doesn't allow that kind of conversation to take place in a smooth, seamless fashion.
Great. Thank you for that. So we'll come back. Iona, are we ready for Yael to start?
I'm ready.
Oh, good. Okay, we'll hand it over to you, and delighted you're with us.
Okay. So, first of all, hello, everybody. This has been a little bit challenging with the technology. My name is Yael Applebaum, and I'm a practicing family physician in Jerusalem, Israel. I'm also a patient safety champion of the World Health Organization. And what I'd like to talk about today are the skills and the pitfalls in communication between the physician and the patient in primary care. These things have bearing upon medication safety. So I'll start by saying first how much you can't see this slide? Okay. How excited I was by the poster, 5 questions to ask about your medications when you see your doctor or nurse or pharmacist. When I read it, I was trying to think, what are the barriers that actually could cause problems and might cause safety issues when we try to implement these questions? So I'm going to divide my talk today to 3 questions. Okay, so the first question is, do we speak the same language? The second question would be, are we making too many assumptions? And the third one, are we asking the right person the right question? I think those 3 topics will cover 3 aspects of communication that can pose dangers to medication safety in primary care. And I think the best way to present this would be to actually give you a few examples of these problems so we can experience them together and see if we can think of any solutions. And even if we don't find too many practical solutions, even raising awareness will help increase patient safety. So the first question would be, do we speak the same language? And when I say we, I mean our patients and physicians speaking the same language when we talk to each other in the clinic. I'm going to start with a common story from my own experience in my practice. Often a patient will come in and say, well, I think those little white pills that you gave me are causing me dizziness. And when I hear that, in my mind, I'm thinking, which little white pills? There are hundreds of little white pills. And even within the pills that he is taking, there are probably a few different little white pills. So the patient might be speaking about little white pills. The physician, on the other hand, might reply and say, well, did you mean that tamsulosine? And the patient will be thinking, hello, how does she expect me to remember such an odd name? I can barely pronounce that. So we are speaking different languages, and sometimes it will cause frustration because the patient wants to stop that little white pill, and the doctor wants to know which pill because he doesn't want him to make the mistake of stopping the wrong pill. So what are the facts?
Yael, if you wanna, your slides were not advancing, so I will do that for you.
Okay, so you'll know when to do it? Okay. So what are the facts? Next slide. The facts are that doctors prescribe medication, but usually they do not know what the pills that they prescribe look like inside the packaging. Different drug companies might manufacture the same medication, but inside the medication looks different. So the same generic medication might be a white pill or a yellow pill. In addition, many pills look alike, even if they are totally different medications. Names of medications are often not user-friendly. Can you show the next slide?
Yeah.
Next slide. Okay. they're not so user-friendly. So it is quite understandable that patients might not be able to pronounce, let alone remember, very long names of medications. So this is something to think about when we talk about medication safety, and it's also something to think about when we look for solutions. So I'm just going to suggest now one local solution that I did with my patient in order to overcome this problem of not being able to speak the same language when talking about medication. And that is specifically when we keep in mind, no, go back. When we keep in mind that many patients with chronic disease have multiple chronic diseases. So they're going to be taking not just one little pill, but often they are taking 6, 7, or 8 different pills. Now, in our country, when you buy medications, you will get them in their original packaging. Can you go back to the slide before?
Mm-hmm.
So the pharmacy is allowed to dispense the generic medication from any company that he has in his inventory. So you see that there might be a few different companies, each selling the drug with their own brand names, colors, packaging, and even shape for the same medication. So a patient might be getting different looking medicines each month, which can be very confusing. So I teach my patients, can you go to 2 slides ahead, please? I teach my patients that on the box of each medication, there is always the brand name, which is written in bold letters, and underneath it, there is the generic name, which is the true ingredients of the pill. So if they keep the name from the box of the medication and save it, next slide, they will be able to compare to the new package to make sure that they are taking the correct drug. In addition, I suggest that they cut the name from the box and insert it in their wallet so they have it on hand wherever they go, especially at any encounter with healthcare givers. They won't have to remember the name, and I won't have to recall what pill is white, green, yellow, or brown. So we will be able to speak the same language. This is a suggestion to try to overcome this problem, and it has additional benefits for the medication reconciliation process. Okay, so the next question that we're going to discuss is making assumptions. I'm going to start by telling you a story about a patient of mine, a young mom who came to me with her child who had a fever, congestion, and was throwing up. So upon examination, the baby had a raging ear infection. So I prescribed medication and suggested that she give the baby Tylenol for the pain. I told her that she might try suppositories because the baby was throwing up. Mom went home, and I told her I'd like to see him in another 2 days to see how he's doing. 2 days later, next slide, the mom comes back, and she says the baby is doing a little bit better, but she's been having a lot of trouble because she kept inserting the suppository in his inflamed ear, but it just kept falling out. When a physician will hear this story, he will chuckle, because isn't it obvious to everyone that suppositories are inserted rectally? It might even be obvious to a good part of the population, but not necessarily to everyone. So what I learned from this story is that I have to be more careful when communicating, and I have to explain things that might seem very obvious to me. I should not make assumptions that other people will be thinking just like me or will understand what I mean. Now I'm going to share another story that will show exactly the opposite when the patient is making an assumption. So Albert is a patient of mine who is 78 years old. He comes in with his wife who is concerned that her husband has become forgetful and thinks he might have dementia. On examination, he is quite disoriented, so I agree with her that this is a worrisome symptom and we must see what's going on. I sent him to various medical testing. He had a brain CT. He went to see the neurologist, and he returns with the diagnosis of new onset dementia, possibly Alzheimer's disease. The neurologist gives him a medication that is supposed to prevent deterioration of this dementia. When they come back, Albert's wife says to me, "Do you think I can give him this medication together with the medication that he got from the dermatologist?" And then I open his file and I say, "Well, what medication did he get from the dermatologist? I have no documentation of any such medication." This discussion in my office now reveals information that the patient has been receiving a very potent antihistamine from the dermatologist for 2 months already because of some kind of rash that he had. This very potent antihistamine can cause dementia-like symptoms in the elderly, which basically was what happened to Albert. I immediately stopped the medication that the dermatologist had. Lo and behold, the patient recovers this so-called dementia. When I asked Albert's wife, well, why didn't you tell me that he was taking this before we did all this investigation? Next slide. For his dementia. Her reply was, I just assumed that you received the letter from the consultant and knew what medication he was getting. For some reason, which I don't know until today, this letter was not sent, and therefore I did not know that he was getting another medication. Had I known ahead of time, that would have prevented this whole neurological investigation. These assumptions that we make are not far-fetched. They are actually very natural assumptions. Yet they do pose dangers in medication safety. Next slide. A witty person once said, can I have next slide? That when you assume things, you make an ass out of you and me. And indeed, we can see how making assumptions can cause problems in medication safety. The last thing I'd like to talk about has to do with the poster, which says, please ask your doctor, nurse, or pharmacist. And it doesn't tell you what you should ask your doctor, what you should ask a nurse, and what you should ask your pharmacist. Things work differently in different countries or different setups, and yet patients might not know who to ask what question. Just as an example of this, next slide, a patient might ask me, is it better to take pills with orange juice or iced tea? And that's a question which I don't necessarily know the answer to. Knowing for each medication if there is some problem with the absorption with different fluids is what the pharmacist has to know in my country. So you would have to ask the pharmacist about how to take the medication, and yet you would have to ask the physician about interactions with other medicines. So we have to be careful how to ask, what to ask, when to ask, and whom to ask. And if as patients we ask the wrong person the wrong question, we should continue asking on till we find the answer. Next slide. So thank you very much. I'd like to just review some quick take-home messages. Next slide. So we must be more aware of all these pitfalls in communication in order to enhance safety. Sometimes we speak different languages, and that can interfere with patient safety. Only if we understand these obstacles can we try innovations for improvement. Even when we have good questions, we must make sure we are asking the right person, and we should try to minimize our assumptions and be more explicit in our discussion. So thank you very much for listening, and I'll be happy to hear any feedback or any new ideas that you can suggest based on these messages.
Great. Thank you so much. I just want to take a comment from the chat box that was sent before your presentation, but it relates so much. Person said, I'm trying to build a culture of safety and empower the residents and families to ask questions regarding medication in our facilities serving Chinese seniors. Medication safety is a standing agenda for the Family Advisory Council now, and it's working well. I think it reflects to your idea of making so many assumptions, and when you have diverse cultures coming in the healthcare providers like we have here in Canada, people make all sorts of assumptions. So I thought that this comment that came before your presentation resonates fully.
Indeed.
Theresa, I'll turn it over to you now.
Okay, and can everyone hear me?
Yes.
We are having been an interesting. So we have some time for some questions. Thank you, Yael, for that very interesting presentation and some very practical solutions. I was very interested in your idea about having patients keep track of the labels from their medication packages. Is there a way you help them to sort of go through how to keep them organized, or how they then remember which label is coming from which? Like, have you had a particular patient that's really done that well? Could you talk about that?
Well, actually,
how they've organized those labels?
The idea of doing this, taking off these labels from the box and putting in their wallet, came from a patient of mine who was, you know, in Israel, not everyone can read English as well as, you know, in Anglo-Saxon countries. So they even had a hard time even reading it. So he came to me and he would cut out these things and say, this medication is what I need, and this medication I don't like, and he would show it to me. And then I adapted that, his idea, and every time I have a patient with new medication, I would tell him to do this. So this is actually a patient, a good idea that came from a patient who found a solution.
Wonderful. And something just so simple. Is there something you do also to help them to realize, like you mentioned about who to ask questions to? Do you help them sort of have a way that you help them sort that out?
That's always very hard because, as someone mentioned before, it is really a culture issue, an age issue. You know, younger people will go on the internet and look for all kinds of solutions, and they will have someone to ask their questions to. Sometimes older patients or patients from different cultures might be more passive and will not ask the questions. So you'd have to, as a physician, you'd have to adapt yourself to who the patient is. And often they won't ask questions. You have to kind of prompt them to ask questions by saying, are you sure you understand? Should I explain it once again? But putting on a poster like ask me is also a good thing because it helps people who are more reserved to get the courage to come in and say, I'd like to ask you this question.
So just having that physical poster there, you're giving them, letting them know, I want you to ask me questions. That's a great idea.
Of course, I always ask them at the end of the visit, did you understand? Should we review this? And I often would write it down on a piece of paper and I tell them, hang this on your refrigerator. That's another thing that I do, you know. But it's in my opinion, it's better when the patient asks because it means he thought about it and it means it's something that's bothering him or interesting to him.
Okay, thank you for that. I see now that we do have Helen up, and we have a few minutes. I'm sure that Helen could work some magic and maybe condense her ideas, and that will be the final part of our presentation today. So I'll hand this, and I'll go back to reminding you, I think we did do an introduction to Helen. She's the co-chair of Patients for Patient Safety Advisory Group for the World Health Organization. So over to Helen.
Can you hear me?
I can. Go ahead.
Oh, that's,
so you
that's
have
wonderful.
A minute.
Okay, thank you. Well, I will, have you got my slides up, Theresa?
Yeah. Yes,
Are
we're
we on the one that says what you can do?
Yes.
Okay. So I'll just go through this very quickly. A lot of it Jaren has talked about really briefly, but so I am the chair of the Patients in the Public Working Group for the Medication Safety Challenge, and we have been working on recommendations and things that patients can do. So next slide, please, Theresa. So this is just the web page, which I believe Jaren also mentioned. You can access all the tools and resources that are available now and that will be available through the WHO Patient Safety web page, which has a link to Medication Without Harm. Next slide. The brochure is a very sort of succinct and readable description of everything, and it's something that's really usable for if you want to talk about the challenge, learn more about the challenge and talk about it to groups that might be interested in helping or government officials. It's a helpful document. On the web page we have stories We have about 17 from different parts of the world about different kinds of medication errors and things that people have done, both providers and patients have done to address them. We will be doing another round of stories, so if you have stories that can be very, very brief, just send them to me. I'll give you an address at the end of the talk. Again, these are some of the materials that are on the website. There are flyers and posters and banners and buttons. The little round no check ask is a button. There are things, again, that you can use to try to raise awareness in your country, useful tools. But next slide, please, how you can help. There are a number of things that you can do. As Jaron said, the challenge is sort of a work in progress. We're rolling it out. This is the most complex and the most ambitious of all the challenges that we've had yet. So it's going to roll out slowly over the next few years. But as things become available, you can download them, you can share them with, with other groups, with advocacy groups, with government officials. Contact your health ministry and ask them, what they're doing about the challenge. Make sure they're aware of it, because this is really one of the critical issues in patient safety. It's a fundamental issue. A huge percentage of all patient safety issues, as you heard in Kathy's story, start with the medication. So educate yourself and teach others to do the same. We've got some really good resources. ConsumerMedSafety.org in the U.S., run by the Institute for Safe Medicine Practices, has a lot of really good information. There are other ones in Canada, and let's see. Reporting adverse events, I think, is really critical. I'll talk about that a little further down, but we definitely report them to your providers. In many, many countries, there are also ways to report them to an official data bank. And you can always report to the manufacturer if you think it is an issue with the medication. And even if it's a medical error, it is something that the manufacturer and regulatory authorities need to know about, that this is something that can go wrong with that medication. So send in your stories to us and then join our safety email list, which I will give you at the end of the talk. So next slide, please. These are just some common gaps that people have. I won't go over this since I see we're almost out of time, but people often know less than you might think they would. So it's important to sort of query and find out what the gaps in their knowledge are, and some of the questions that they ought to ask. They need to have a goal when they're taking medication. Think why they're taking it, not just follow directions. Next slide, please. So the things patients need to know: information on high-risk drugs. This is the sort of thing that will become available on the medication safety webpage, especially when we have 3 technical reports and a revised curriculum that will be coming out that will have these kinds of details. They'll be very informative for everyone. And also ConsumerMedSafety.org has specific information on specific drugs, which is the information people need. Actions you can take, I've already gone through some of that. Having a medication app and a medication list is really important. These 5 questions from the CPSI are very important for people who are in a relationship with a healthcare provider. We are working, as Darren said, on a tool called 5 Moments for medication safety that's sort of mirroring the 5 moments from hand hygiene, which were very successful. The idea being things that people should think about at different points along their medication journey, since not everyone in every country really has access to a professional to talk to. There's an example of a medication passport. This is from Institute for Safe Medicine Practices at Consumer Med Safety. There are many others. They're all over the internet. We will also be developing one from Patients for Patient Safety at WHO. That will be coming out soon as well. Medication app, the MyMedRec from Canada is really an excellent app. There are others. Some are intertwined with the country's regulations and healthcare systems, so the providers can fill them out for you. Japan is a good example of that. And then pharmacovigilance. This, I know, I see we're almost out of time. But this is, I did want to talk a little bit more about reporting. So you can report, this map shows all the countries in the world. And if you go to the UPSLA Monitoring Center, the address is there, who-umc.org, you can click on your country and see the center to which you or your healthcare provider can report an adverse medication event. So you can not only report to your provider and to the manufacturer, but you or the provider can report to this center. And the pharmacovigilance centers are very aware of the need for consumer reporting and are working on having that available everywhere. And finally, you can look at the Patients for Patient Safety webpage on the WHO website, and that also has patient materials that are updated from time to time. So you will see these tools there as well. And that was not final. Finally, join our email list. It's not actually an email list, but an email group. So if you email medsafetyptp@gmail.com, we can add you to that list so you'll get updates, resources, and engage in discussions about things you can do and offer suggestions. We would be very grateful to have your suggestions. Thank you all so much.
Thank you, Helen, for that and I'm going to hand this over to Iona. I know she has a last few comments.
Yes, which I'm going to keep short. So all those slides that you see at the webinar, including the hyperlinks and email address of the presenters, will be shared with all of you after, including with a recording. So we have it for our records. There were a few questions that we didn't get to answer or not answered completely. So I'm going to ask the presenters, especially there was one on electronic health records and electronic prescribing of medication. So I'm not sure how much we can answer that, but in the registration form, that was an area where some of you had questions. I do hope that we left you with a few practical ideas and tools that you can use to advance safe medication. Even if you're care providers, a manager, a leader, or if you're a patient or a family member, we hope that each of you have something to do. We will send you a short evaluation after the webinar via email to all of you. And in that evaluation, we will ask you, what do you want to hear at a future webinar? As Theresa has mentioned, this is going to be a series, so we're going to try the best way we can to address as many of your needs as we can during those webinars. So tell us what you want to hear. So with this, maybe we'll just see if any of the presenters have any final comments, and then we'll wish you a wonderful day. I know we are a few minutes over time. So any of the presenters who have some final thoughts for the participants?
Thanks, Iona. This is Jaren here. Well, regarding the comment of electronic health records being a solution to this problem, yes, it definitely does help in a lot of errors being avoided, but it definitely avoids illegible handwriting. It definitely avoids when there are confusions with numbers and decimal points in the dosages, those kind of errors. Yes, definitely. But there are also multiple studies which shows that it gives rise to a new set of errors. Like, say, for example, if there was a case where a patient was prescribed olanzapine, but then the physician chose to prescribe lansoprazole simply because both of these medicines have got L-A-N-Z together. So, there are chances of misprescribing. So what's important to note is that there should be due caution at every stage, and also that these solutions need not always be universal, uh, and every country or every institution should be encouraged to do their own risk assessment and then find their pinch points and then address them accordingly. So that's what I'd like to say. And another thing that as patients, uh, what healthcare professionals should expect from patients are motivated patients who would like to know more about their own medicines and about their own diseases. Thank you, that's what I'd like to say.
Sure. Any other comments from the presenters?
No, that's terrific. Thank you very much, Theresa and everyone.
Thank you.
You're welcome. And thank you to our audience members for being so patient this morning. We've had great content and a few technical gremlins.
Okay, well, thank you everyone for joining us today. It has been a great webinar. I have learned a lot, and we'll be waiting for you to join us at the next webinar, the date and topic to be determined, so we'll make sure you get that information. With that, I'll wish you, everyone, a beautiful day or evening, whatever time it is in your time.